Thank you, Chair Sanders and Ranking Member Cassidy, and thanks to all of you for being with us here today. I'd like to start with going at how this system affects folks who don't have health insurance. And so my first work in the Senate focused on this when I met my fellow Minnesotan, Nicole Smith-Holt, and heard about her son Alec, who I believe Chair Sanders raised at the beginning, who died of ketoacidosis when he went off his parents' insurance and couldn't afford his insulin. He rationed and he died. Now, HHS analysis tells us that uninsured patients typically pay the most for insulin, and that, of course, leads to rationing. And so we've heard about your patient assistance programs, and you've argued today that insulin is different and better than it was 100 years ago. Diabetic patients need different drugs, need different insulin based on their body and what works best for them. So my first question to the drug companies: can uninsured patients currently access each of your insulin products through all of your patient assistance programs at somewhere between $25 and $35, which I think is the range of prices?
You start? Yes is the answer. If you're insured, it's capped at $35 for every Lilly insulin. If you're uninsured and your income is below $57,000 a year, it's free.
For all, it doesn't, whatever.
Doesn't matter what
matter
insulin you're on.
It's
Yeah,
all of them.
absolutely.
Okay, Mr. Hudson?
The same for us, and in fact, the data is that uninsured patients used that facility over 100,000 times last year for
Okay.
zero copay.
For all of the insulin
Yes,
products that you
that's
offer,
correct.
not just some
Yeah,
of them.
that's correct.
Okay, and Mr. Jorgensen?
Yes, Senator, we also offer a program where people can get access to free insulin and any insulin if they are in a situation where they have to ration. So we are there for all patients with all insulins.
Okay. So what I don't understand is, because I hear about patients being charged list price if they don't have insurance. So I'm having cognitive dissonance trying to understand how this all works. Why don't you just lower the list price for all of those medications and just make it simple? Yeah. Or any.
Yeah, we would like to get there. Honestly, I think Senator Braun mentioned we'd be happy if there weren't rebates in the system. They don't do anything for us.
So you'd be willing to lower list price?
We have been, as I mentioned in my comments.
So let me just turn to the PBMs, because the drug companies are saying they would lower list prices. You've been asking for them to lower list prices. Can we just have an agreement today that we're going to lower list prices? You won't charge rebates, they'll lower list prices, and we'd be all done? Who wants to?
I can answer that, Senator. So we've been asking for years for them to lower list prices. Unfortunately, the lower list prices are coming far too late compared to when they could have occurred years ago. Now they're coming because of the Medicaid cap that's going away, and so they're going to be exposed and it would have to pay more. So they're actually doing this because of government intervention, not because they just want to lower the prices. But we welcome them to lower the list prices, and we'd be excited to do so for the value it's going to provide to our patients.
Mr. Joyner? I'll come to.
Similar to Express Scripts, we also would applaud and enjoy the lowering of list drug prices.
And then this gap that Senator Collins showed on her chart, which appears to be the rebates and discounts, that then you would get rid of those.
Yeah, I think there's two things. Because one is that's what the PBM has done to date. So the prices that have been announced on that chart is actually below the cost that they've listed for coverage.
Mr. Hudson?
Yeah, just to be clear, that it was 2018 we brought a lower price analog out, nothing to do with recent policies or announcements, and reduced the price of that 3 times to no effect. And then it was last August that we made in the same factory, as I said earlier, at unbranded Lantus at 60% off, long before this year's debate. So I'm a bit perplexed, because they're there, they have been there, we've stepped up and done that.
Too.
Yeah.
Right. To the PBM executives, what do you say to this critique that your profitability is enhanced or higher when list prices are higher?
So I'll give the Lantus example because I think it's an important point that's being made that a lower list price being brought to the market has not been accepted by the PBM. And back in 2017, a biosimilar came to market by the name of Basaglar, which was generic competition in that category. We adopted that product as our preferred product. So we lowered the list price, and we lowered the overall net cost for the customers, and we converted 97% of all the patients on Lantus onto Basaglar. So it was a significant savings for our customers, and we actually embraced a much lower list price than what Lantus was promising at the time.
So this critique that PBMs do better when list prices are higher, does anybody, I mean, is that an unfair critique, or how do you see that?
So, Senator, our focus continues to be for our employer clients and patients that we drive to the lowest net cost, regardless of where the list price is. Lantus is an interesting example. So Lantus, when it didn't have competition between 2010 and 2014, actually doubled in price. The price didn't moderate until 2015 and beyond, when competition actually entered the market. Discounts were about 3%. They increased to about 20% in the 2015 range, and then certainly have more than tripled since that point. So just to the questions earlier on products, other products in other countries and how expensive they are, unless there's competition in the market and for us to drive that competition, you're going to continue to see sky-high list prices by drug manufacturers. We're going to do everything we can to bring those prices down, and that may be in the form of rebates so we can provide discounts back to our employers and our patients.
Well, so let me just follow up on that a little bit with you if I could. Actually, Senator Braun and I tomorrow we'll be marking up legislation that Senator Braun and I have introduced that would basically be a bill that would help bring lower cost generics to the market more quickly. But of course, that only benefits patients if they have access to them. This is another place where I'm having cognitive dissonance, because this brings me to the formularies that basically determine what medicines patients can get at what cost. And a recent study showed that in Medicare Part D, a greater proportion of generic drugs are being placed on higher tiers on formularies, which leads to increased patient cost sharing. And another report showed similar trends, forcing patients that actually, so they end up paying more for generics because of where, what tier they are placed in on the formulary. So can you explain, how you see that? What's going on there? Why is that happening? Why does it appear that lower cost generic benefits are not getting passed on to patients like we would have expected and hoped?
So, Senator, we are absolutely supportive of legislation that could help to improve the accessibility to generic drugs, that will remove patent thickets, remove pay for delay, and will provide faster accessibility to more competition in the market. And we welcome anything that can help to do that. On the biosimilar front, we also welcome reducing the patent expiration down from 12 years to 7 years to create more competition, and interchangeability rules as well on biosimilar products so that it's easier for biosimilar manufacturers to come to market and actually be competitive.
Thank you, Mr. Chair.
Okay. Thank you, Senator Smith. Senator Marshall.
Thank you, Mr. Chair.